service barriers linked to health inequalities do adolescents experience in Europe? Danielle, the floor is yours.
Hello, everybody. I start my presentation by first explaining what health system barriers are. Health system barriers are those barriers that affect the delivery, the service delivery system. And these barriers are associated with the structure and processes of service delivery. One framework with which we can highlight the essential components of a health system in which barriers and enablers are operating is the WHO Health System Framework. This very well-known and instrumental framework has been widely applied across the globe and describes 6 core components or building blocks. You can see them at the left of the slide. These are service delivery, health workforce, information, the availability of medical products, vaccine and technologies, financing, and leadership and governance. And these building blocks high in the access and improve the coverage, quality and safety, and at the end leads to improved health outcomes. Strengthening the health system means improving these 6 health system building blocks and managing their interactions in ways that achieve more equitable and sustained improvements across health systems and health outcomes. The WHO Health System Framework can be applied to improve the overall population health in a responsive, financially fair and most efficient way. And incorporated are the vital indicators addressing health inequities, namely availability, accessibility, affordability, and quality. So who are the vulnerable or the underserved adolescents? Underserved populations are those who have been shown to have disparities in access to care and in health status. There are many categories of underserved adolescents. And on this slide, I do not provide an exhaustive list of underserved adolescents, but my main aim is to give you an impression. First of all, adolescents with an immigration background. For example, the 1st and 2nd generation adolescent migrants in the Netherlands, which means that they are born abroad or born in the Netherlands and having at least one parent that was born abroad. Second, adolescents with a low socioeconomic status. And third, adolescents from ethnic minority groups such as the Roma in Central Europe. And in her presentation, Susan already mentioned the indigenous population. And although indigenous populations are not the same as ethnic minority groups, they often share a history of exclusion and discrimination based on identity, and which led to high levels of poverty among them. So now you know at what level health system barriers can be found, and you know some of the underserved adolescents. And I will now share some information on experienced health system barriers linked to health inequalities in adolescents in Europe. And I will do that based on information of 2 projects. One is the soon to be started Horizon 2020 project, RIVER EU. RIVER stands for Reducing Inequalities in Vaccine Uptake in the European Region, Engaging Underserved Communities. The other project is MOCA. It stands for Models of Child Health Appraised. And in this project, we explored primary healthcare for children and adolescents in 30 European countries. In this table, you see the countries with underserved populations we have chosen for our RIVER EU project. We choose these 4 different countries and populations because they experience a low measles or HPV vaccine uptake compared to national uptake. And these populations also experience barriers in immunization health systems that contribute to the low uptake. And finally, we chose these countries and populations because our partners in those countries do have strong connections with the government, with the most important national stakeholders, and with the underserved populations themselves, which is necessary to engage them in the research. And in this table, you see the WHO building blocks, and per country, which barriers in the building blocks are established. And you see in the Netherlands, we have, well, only 2 barriers found, and Slovakia has barriers in 4 of the WHO building blocks. The first experienced health system barrier is the lack of reliable documentation and health information system. In Greece, Poland, and Slovakia, there is a lack of documentation of vaccination and medical history of the underserved adolescents, which is necessary to understand and compare data and for taking action if needed. In addition, in some cases, the adolescents do possess false immunization certificates. The second health system barriers are the experienced challenges in accessing credible online vaccination information in native language. This was the case in the Ukrainian migrant adolescents in Poland. The third health system barriers are intercultural communication difficulties. Many underserved adolescents experience barriers in communication with healthcare professionals, and these barriers often result in the indirect unavailability of vaccination services. The fourth health system barrier is the lack of well-trained and well-equipped staff. Many Turkish and Moroccan adolescent girls and their parents in the Netherlands have negative beliefs and attitudes about HPV vaccine safety and effectiveness. They have the conviction that HPV vaccines can be extremely harmful, which lead parents and female adolescents to refuse or delay vaccination for HPV. Until now, staff in the Dutch health system is not trained well enough to address the HPV vaccination beliefs and attitudes of these adolescents and their parents. The fifth health system barrier was the absence of a doctor to approach when needed. Especially in the Roma settlements in Slovakia, there is no doctor available, which hinders the path to further services. The sixth experienced health system barrier concerns the high cost of vaccines and transports to vaccine services. Self-paid HPV vaccines are not of interest for people living in Ukraine, as well as for the Ukrainian migrants to Poland, due to the high costs. In Slovakia, the lack of governmental financial resources leads to disruptions of programs focusing on the improvement of Roma health, also related to vaccine preventable diseases. Transport and medical costs are additional barriers to accessing healthcare services. Among the Slovak Roma community, over 9% could not afford or did not want to pay a fee for immunization. A seventh health system barrier is the link with immigration authorities. Adolescent migrants without documents in Greece are discouraged from accessing government-associated health services because of the links with immigration authorities. And a final health system barrier in one of the 4 selected populations was discrimination. The discriminative attitude of some healthcare professionals in Slovakia prevents adolescents of the Roma population from seeking help. In the coming minutes, I will tell you more about experienced health system barriers linked to inequity in adolescence in Europe. These are the health system barriers related to primary mental health services, sexual and reproductive health services, and school health services. On this slide, I'm showing the experienced health system barriers in primary mental health services. The first barrier is lack of professionals trained in intercultural issues. Adolescents having migrated recently, with or without being accompanied by the parents, often need expert professionals trained in intercultural issues. Only one of the included European countries, Slovenia, had such a professional throughout the whole country. In another 18 countries, it was the case in some parts of the country, mainly in large cities. In other words, in 12 of the 30 countries, there were no such professionals available at all. The second health system barrier is the absence of a translator. One simple way to assist primary healthcare professionals is to provide translation. In only 18 of the 30 countries were such translators available when needed. The third barrier is payment of services. In several countries, co-payment for mental health services existed up to the age of 18 years. In five countries, adolescents or their parents did have to co-pay in specific situations or circumstances, such as long-term outpatient psychotherapy, receiving additional services during hospital treatment, or being referred to a psychologist. I'm sorry. On this slide, I'm showing the experienced health system barriers in sexual and reproductive health services. The first two barriers are related to payment of services. In only 11 of the 30 countries, oral contraception is free of charge, but often under certain conditions, for example, at a reduced price from 18 to 20 years of age. In several countries, termination of a teenage pregnancy is covered by the insurance company, while in other countries, the expenses have to be covered by the adolescent's parents. The third barrier is related to privacy and autonomy of the adolescent. In some instances, the situation of a minor adolescent may require the termination of the pregnancy without the parents knowing. This may, for instance, occur when there is a risk for the adolescent being forced to marry or being sent back to her country of origin, or when there is a risk of the girl being molested or seriously beaten by her relative. And we also had done some research 10 years ago, and to a large extent, our results show that little has changed since 10 years ago. So these barriers I am now mentioning were also the barriers that existed already for 10 years. On this slide, I'm showing the experienced health system barriers in school health services. On the question, what should be improved in school health services, 14 of the 30 countries reported that inequalities in access to school health services in the countries is an area that still should be improved. Finally, only 18 of the 30 countries had a policy to improve integration of adolescents in school and to encourage education of vulnerable pupils. But in 13 countries, no such policy existed. And not going to school means no access to school health services for these vulnerable adolescents. My conclusion, adolescents experience many health service barriers linked to health inequalities. And the experience barriers cover most, if not all, of the WHO building blocks. And these health service barriers lead to less access and more health problems. And we have sufficient starting points to start removing health system barriers. So I think it's time for action. You may never know what results come of your action, but if you do nothing, there will be no results at all. Thank you.
Thank you so much, Danielle.